This program is brought to you by Emory University.
Welcome, everyone. We're going to get started. Just so everyone is aware, we are video and audio taping this session. There's, as I mentioned, pizza out front, a sign-in sheet. We hope everyone will sign in, and the restrooms are around to the right, and I think we've taken care of housekeeping. So, I'd like to welcome everyone to the first session of the Emory Ebola Faculty and Community Discussion Forum. Emory University is leading new knowledge in the management, patient care, public health, national and global policies related to pandemics and global emergencies. The Emory community is engaged in global efforts to specifically address the Ebola epidemic in West Africa, the largest outbreak of this deadly disease in history. The Ebola response can be seen as a case study, helping us with global emergency preparedness for the future. Unlike the rest of the U.S. population, whose interest waxes and wanes, I guess due to media, terrorist attack, and because I think we all probably have the attention span of gnats anymore with what happens in the media, our academic interests and our global public responsibility needs to go way beyond the U.S. public's interest. We have great opportunity here at Emory and with our partners across the globe. The Emory Ebola Faculty and Community Discussion Forum is supported by every single school at Emory University in Oxford, and we thank Candler for hosting today's event. We are collaborating with the sponsors on this community-wide forum to explore multiple integrated dimensions of the impact of a pandemic on public health, on development, governance, public policy, law and civil liberties, economics, ethical considerations, religion, and culture. Our speakers include experts from across Emory University, from the Carter Center, including President Carter himself, as well as from the CDC, and importantly, from our partners in West Africa. The forum has been organized by the Nell, Hodgson, Woodruff School of Nursing, the Institute of African Studies, and the Institute for Developing Nations. So I would just like to take a minute to introduce the three co-chairs of this event, which would be myself, Dr. Pamela Scully, Dr. Sita Ranchad-Nielsen. I am a professor and the Robert W. Woodruff Chair of Nursing and Director of Faculty Mentoring in the School of Nursing. I'm an Associate Director for Outcomes in the Winship Cancer Institute, and I serve on the Emory Ebola Task Force. How this forum came about was that I served on the Emory University Commission on the Liberal Arts, known as COLA, for the last 2 years, and one of the recommendations from COLA, and it was approved by Provost Stirk, was for building common intellectual experiences across the university. COLA recommended selecting major university events, especially those unique to Emory, and building orbit intellectual events around them. And I can think of nothing more unique than Emory's successful and ethical response to the Ebola crisis. Thus, this was inspired by the COLA recommendations. One of our co-chairs, Dr. Pamela Scully, is the Assistant Vice Provost for Academic Innovation and Professor in the Department of Women's Gender and Sexuality Studies. She's also Professor of African Studies. And Dr. Scully is completing a book on Ellen Johnson Sirleaf, who is the President of Liberia. Dr. Scully works closely with the Institute of Developing Nations and the Carter Center. Our other co-chair is Dr. Sita Ranchad-Nielsen, who is the director of the Institute of Developing Nations. And since 2007, she has led IDN's effort to build a community of scholars, practitioners, and policymakers who are committed to working together to fight global poverty. Through fostering partnerships with the Carter Center and others, the IDN is working to transform how we think about and how we do development. IDN has supported projects on gender-based violence and rule of law in Liberia, and gender and transitional justice in post-conflict societies such as Africa and South America. Now, additional information about and resulting from this forum will be shared on the IDN website, and you can see that there. So please follow us throughout the semester. We will be posting the videos of each open event, and hopefully there will be lots of other things we will be posting, including resources and some of the discussions that are going to occur. We anticipate that the activities will not end with this forum. We expect that they're going to continue, and possible areas include curriculum development, research, and partnerships and capacity strengthening collaborations. So the point was to begin a dialogue to let you know who's working in this area, who wants to work in this area, who our partners are, and hopefully have more people participate and join in. Finally, we are going to be posting the open discussions on Twitter, and you can see it here, Emory Ebola Forum, hashtag Emory Ebola Forum. So please participate. If any of you want to post questions during the panel session, if there is time, we'll go to the Twitter feeds and we'll look at some of those questions. So I'd like to move into our introductions. Before I say that, we're going to hold questions after each speaker until the panel session, and we'll take all questions at one time. So it is my distinct pleasure to introduce our first speaker kicking off this forum. Dr. Carlos Del Rio is an MD and the Huber Professor and Chair of the Huber Department of Global Health and Professor of Epidemiology at the Rollins School of Public Health and Professor of Medicine here at Emory. He is the Director for Clinical Sciences and International Research for the Emory Center for AIDS Research and Director of the Emory AIDS International Training and Research Program. Dr. Del Rio's research focuses on the early diagnosis, access to care, compliance with antiretrovirals, and the prevention of HIV and other infectious diseases. Dr. Del Rio has co-authored 30 book chapters and over 300 scientific papers. We welcome Dr. Del Rio.
Thank you, Deb. Thanks, Pam and Sita, also for organizing this. I think this is a really good idea and hopefully part of a wide discussion that is going to touch on many topics. I think that this epidemic has taught us a lot and will continue to teach us a lot, and hopefully as an academic community we can also use this to move forward. So can I have the first slide? My task today is to tell you a little bit, sort of introduce the topic of Ebola and where we are and how this relates to the current discussion. Sort of set the stage and for that I am going to try to help you recognize sort of the characteristics or transmission routes of the virus, describe the epidemiology of the current outbreak, and list some of the characteristics and management of patients with Ebola, and to talk a little bit about this whole issue about prevention. So the Ebola virus belongs to a family of viruses called filoviruses that have two genera. There are RNA viruses, and there are several species of this virus, and of this species, all of these infect humans and non-human primates, but this last one produces infection but not disease in humans. So no, everybody thinks this is a fatal disease, but we know that there is some degree of immunity and protection that can happen. It is transmitted by contaminated body fluids, and typically we've heard that this is a disease with very high mortality that has ranged from 40 to 88%. But a lot of it is based on essentially providing no care. This is a disease that typically has occurred in very remote areas. So when we talk about this mortality, it's mortality under no care. And I think some of the experience here at Emory has taught us that the mortality is probably not 40 to 80% here at Emory. We're very proud to say the mortality here at Emory under the leadership of Dr. Ribner, who's sitting here, has been zero. So, you know, mortality in Emory is zero. Mortality in Dallas is 100%. In Liberia, somewhere in the middle. This is a schematic of what this virus looks like, and I'm not going to tell you a lot about the virology. I'm going to tell you is just explain two things of how this virus sort of outsmarts the immune system, and we've known and we're learning more about how this virus manages, for example, through production of a protein called VP35. This virus essentially inhibits the production of a protein called interferon. Our cells, when they're infected with a virus, produce something called interferon that essentially coats the cells and prevents future virus infections from happening. Well, this virus actually produces something that inhibits the production of interferon. So in a way, it's not allowing the cells to defend themselves, to use this mechanism of defense to protect from a virus. It produces another protein, this protein BP40, that actually what it does is interferes with RNA interference, with the production against ability of the cells to stop production of viruses inside cells. So the virus, in a way, hijacks the ability of the cells to defend themselves as part of the way that, we frequently think about HIV, well, destroys the immune cells. Well, this virus also is doing something similar. It's kind of preventing the immune system from attacking it. It produces a protein as the virus is being produced. It has a protein in its membrane that has it essentially binds to the antibodies that we're producing. So again, the virus, we're learning a lot about the immunology and how do we defend ourselves from this virus. And it's very clear that that looking at the immune system and the virus is something that we here at Emory and many of our researchers at the Vaccine Center are going to contribute a lot into this epidemic. There's been animal models of this disease that have been used, and animals like small rodents are really not very good models because they basically they don't reproduce what happens in humans. And a good example of that is bats. Bats get infected but don't get sick, and the same thing happens with rodents. However, non-human primates have been used and are excellent models for this disease because they show very of the similar characteristics that humans do. And again, because here at Emory we have a primate center, a lot of work in Ebola. I mean, we're well positioned to do a lot of the work that is needed in understanding pathogenesis and pathophysiology of Ebola. The virus is transmitted, as I said, through infection by being in contact with essentially infected secretions. It is a disease of what we call zoonosis, and zoonosis means diseases that are typical in animals, and they sort of enter the human ecosystem and environment, and then we get infected. And as we have learned in infectious disease lately, a lot of the infectious disease that we're dealing with, the new outbreaks of infection, whether it's HIV, whether it's influenza, whether it's Ebola, are zoonosis. We as humans are encroaching on the jungle. We're entering places we've never been before. We're coming in contact with animals we've never been before. And again, Ebola is just one. We will see more infections emerging that we didn't know about, and I bet you most of them are going to be zoonosis. So clearly working with our friends in veterinary medicine and understanding what they're seeing in animals is going to be very important in understanding human health. The infection goes through a process of what we call amplification, and the reason for that is because if you're in hospitals or in the community taking care of an ill person, then that disseminates, that increases the possibility of infection. So people taking care of others, whether it's in the community, at the household, or in the hospital, are at high risk of infection. And you're going to see that if we're dealing with populations where there's not a lot of healthcare providers, to have healthcare personnel die of this infection is actually bad. So to me, it's fascinating to see how this epidemic started, because now we know that it started somewhere in December of 2013, probably with one single case, one kid that, again, was playing or doing something in a tree that was full with bats. And that's what the ecologists have been able to figure out by doing DNA and other things, that it started with one single introduction. By March, they were probably around 40, somewhat 50 cases and about 29 deaths. And in a course that I teach at the School of Public Health in International Global Infectious Disease that I've taught for many years, Dr. Pierre Rollins from CDC typically gives a talk on viral hemorrhagic fevers, and he had just finished his talk. And then the next week, he sent me an email saying, whoop, I'm out to Liberia to this outbreak. And he's gone to multiple of these outbreaks, and he knew of probably a couple weeks and things will be under control. And then all hell broke loose. It was like nothing he's ever seen before, and his communications were just fascinating in this respect. Because you can see very rapidly this started spreading to other countries, and it started going to other places. And by a couple days ago, and again, Dr. Ribner and I were talking about this, that the numbers are just the numbers. They change every day. They change daily. You don't need to worry about that. What you need to worry is that this is worse than that has ever been seen before. There's over 21,000 people that have contracted the disease, over 8,000 that have died in these countries. But there are some countries, Nigeria now, Mali, and other countries who the disease went in, and now they've been declared Ebola free. So there is things we can do. There are things these countries can do to take care of the infection. talking about the country context, and more will be talked about this. This countries, Guinea, Liberia, Sierra Leone, are countries that in general have been really had a lot of things happening in them, whether it's a civil war, civil disobedience. But the big driver of this epidemic has really been poverty. When you look at what is driving the epidemic, and we need to think about poverty, and we need to address global poverty as a concern. When we think about addressing Ebola and not thinking about addressing poverty, I think we're just not thinking about the entire picture. This will continue to happen as long as this severe poverty continues to be something that occurs globally. I told you that the disease started somewhere in December. By March, people were paying attention, but it wasn't really until August that the WHO declared this a public health emergency of international concern. And this is essentially when the WHO can say, well, we consider this an extraordinary event, and we can now use the international health regulations to go in there and start doing things. So again, the international response has not been very fast. And in fact, I think one thing we've learned about this is that it has taken a long time for the international community to wake up to this epidemic. And if there's anything good about the cases coming here and coming to Europe and other developing countries, is all of a sudden people have actually woken up. If this epidemic has just stayed in Africa, like multiple others, people would have paid no attention. So clearly, the international response has also been very slow to wake up, and now we're having to go back and backpedal on it. The WHO is obviously in a very difficult situation, and so has been CDC and any other organizations, in that the international response and the local response has been slow, in great part because global public health and local public health has been significantly underfunded. We have been cutting budgets over and over and over, and you can see, that's not a very good strategy, because all of a sudden now the globe is having to put a lot of money into this response. Just here locally, in the U.S., the president had to go and ask for $5 billion to supplement CDC's budget to respond to Ebola. And it reminds me, Dr. Fege used this the other day, and I thought it was very good, that Dolly Parton used to say that it's really expensive to look this, you have no idea how expensive it is to look this cheap. Well, if by cheaping global public health, it's now becoming very expensive. And I think we have seen this nationally and globally, is that people start cutting budgets in public health, and then of course then the international response simply is not there to take place. We talked about the impact in healthcare workers, and I just want to mention, just to give you an idea, Liberia has more than 86,000 populations per physician, and Sierra Leone has about 45,000 per physicians. Those are extraordinarily high numbers of population, extraordinarily low numbers of healthcare providers to serve a population. So it's very hard to say, well, how do we produce a response? How do we take care of people if there's nobody to take care of them? If you add to that, that healthcare workers are actually at increased risk, and you can see the number of infections and the number of deaths among healthcare workers, then you really are in a problem. You really are in a bind. How do you get healthcare workers trained and be ready to respond to epidemics like this if they're putting themselves at risk at the same time? We are an academic institution. We have a Center for African Studies, but it continues to amaze me how little people know about geography. I had somebody fairly well-educated that I saw not too long ago who said, I'm very concerned because my daughter is getting married and she and her husband want to go to a safari in Tanzania, and I don't want them to go because of Ebola. And I was like, what? Excuse me, people have no idea that this is Africa, this is the area that has Ebola, this is the rest of the continent. Africa is massive. This just has here's the United States, here's Europe, here's China, here's India. They all fit inside of Africa. So when people talk about, oh, this is a problem in Africa, no, it's not. It's a problem in West Africa, in a very teeny region of West Africa. And this is having enormous consequences for Africa. If you talk to people in the tourism industry, if you talk to people in the safari industry, for example, a lot of people are canceling safaris and other things because they're concerned about Ebola. So the economic consequences of Ebola are going far beyond West Africa and these three affected countries, precisely because people have ignorance. And I think one of the things that we need to help educate is people really about geography and about what it means and what I remind people that Rome is only about a 3-hour flight from Sierra Leone, and Cape Town is about a 6-hour flight. So I'll be more concerned going to Rome than I would be going to Cape Town if I was concerned about Ebola. There have been a total of 24 people that have been treated outside of Africa and that have been evacuated. And you can see here Those have been treated here in the United States. And here in Atlanta, we have had 4 people in our communicable disease unit that have been under the care of the Ebola team here, and you'll hear more about those later. So we have, if you talk about the experience outside of West Africa, the experience has been greatest here in Atlanta and here at Emory specifically. But we will continue seeing cases. No matter what we do, we can put security at the airports, we can screen people at the airports, et cetera. People will continue to fly, people will continue to go to other places, and we will continue to see patients leave as long as there's an epidemic happening here. So when people say, what do we need to do to control Ebola in the United States or in Europe, it's not closing the air borders, it's not stopping the flights, it's actually controlling the epidemic in West Africa, and that will stop the possibility of people, coming to this country. One infectious disease concept is the concept of the R null, of the possibility of transmission. This is how many cases after an initial infection happens. So an R null of 2 means that after one person is infected, 2 people get infected, and we can go on and on. Here at Emory recently, we had a little outbreak of norovirus, which is like rotavirus. The R null there is about 17. One kid infects a bunch of others, but the mortality is very, very low. You can see other diseases here, and here, for example, is Ebola. The R null is around 1.5 to 2, and the mortality is about 70%. So the key to decreasing the controlling the epidemics to bringing the R null down, and we know the possibility of transmission increases much, much more in people that are very ill because they have very high amounts of virus in their blood. They're sick for a long period of time. So again, getting those sick individuals into care is critical in controlling the infection because they're the ones that are transmitting. So the more somebody is sick at home, the more somebody dies at home, the more likely they are to increase the transmission. And again, an R null of 1.5 or so is pretty scary when you think about the pandemic flu of 1918 had an R null about 1.6. So people get sick, people get infected, and about 1 to 2 weeks after they get infected, but could be up to 21 days, a little bit longer, is when people start developing symptoms. And that is why people have talked about quarantine for 21 days. You watch somebody for 21 days for the development of symptoms. The symptoms are very nonspecific. Fever, general malaise, flu-like GI symptoms could be very nonspecific. They can look like a lot of things that also are very common in this part of the world. Malaria, influenza, you name it. A lot of diseases can look just like that. So there's nothing clinically specific about Ebola. And that leads to people not knowing what it is. It could be multiple other diseases, or it could be multiple diseases plus Ebola. I mean, somebody can have malaria and Ebola at the same time. But once the virus gets into cells, it starts getting into different areas, and the virus by immunohistochemistry is found in liver and spleen, essentially disseminates throughout the body. It doesn't stay in one place. Here at Emory, in late July is when Dr. Ribner received a call saying, we're sending a patient to you, and then we're sending another patient to you, and those are the patients that came here to Emory, and the rest is history. But the question is, why Emory? Well, because Emory has a special pathogen unit here at Emory University Hospital, and you hear more about it. And this unit, again, was set up many years ago as a way to have a place for infected people from CDC or working for CDC who were infected with a high-level category A bioterrorism agent to go to. And Dr. Ribner has been in charge of that unit and has been preparing for this to happen for years. But really, the unit had really not been used. And this is like the fire department. If you don't have it, you think you don't need it until you have a fire. So the group there was very well prepared to do this and had been training for years to get to that point. The unit looks very similar to, you can do a tour of the unit. Dr. Ribner can give you a virtual tour of the unit. And it's basically a well thought up unit that has 2 beds that can double as an ICU bed. And the key is, how do you ensure who gets in, who goes out? How do we control it? How do we do that in a very effective way that is safe for the employees? And I think one of the things that Susan can tell you more and others can tell you more is that ensuring the safety of the employees that go in there and ensuring that they're appropriately trained has been one of the mantras here. And one of the mistakes in Dallas was precisely not doing that, precisely not ensuring that the people going in there had the appropriate training. It's like, me volunteering in the fire department being sent to a fire. I'll probably get in trouble. I've never been trained to do that. But there's no magic bullets. People will call you and say, how about ZMAP? How about this? How about that? Investment friends have called me and said, should I invest in this company or that company? No. There's no proven therapeutics, no magic bullet, but the ability to provide high-level nursing care and supportive care is really what has made a big difference. And I think a big shout-out for the care provided by nursing care. Supportive care doesn't mean holding somebody's hand. It means ensuring that if their potassium goes down, you replace it. If this goes down, you do something about it. And that very intensive nursing care that has happened with these patients has been critical in ensuring that they survive and they do well. And the other thing that they've noted in this unit is that enabling safe interactions between family and patients has also been very helpful. I mean, it's scary to be sick with something that, you can die of, and at the same time you can transmit to others, and, you can put your families at risk. So how do you get over that anxiety that people may have? Again, treatment and isolation of symptomatic individuals is critical. You have to ensure that they're hydrated, their electrolytes are managed, and you have to ensure that appropriate personal protective equipment is used. And here at Emory, one of the things that we noticed is that very early on, we were using, when Dr. Ribner decided to put, what they were going to use for personal protective equipment, you look at the CDC instructions, pretty soon what you realize is you're putting people in spacesuits. And how do you reconcile spacesuits with what CDC was saying you ought to be doing? Well, the reality is you have to think on the safety of your employees. And I think CDC has learned that by having a low level before, they have been ratcheting it up increasingly and have gotten to where we got to begin with. And I think it was a very different approach. The approach here was an approach of absolutely no harm, 100% protection of our employees, as opposed to, well, I think this is the minimum we need. It's a minimalist approach versus ensuring that everything goes the right way. But the most important thing that we've learned here is that putting on protective equipment is not as simple as it looks like. And putting it off particularly. And that's usually when people take it off that people contaminate themselves and they get in trouble. And again, a lot of training has gone into ensuring that people are trained in putting off their personal protective equipment, and also ensuring that you get supervised, that there's a buddy system. Because I can be taking off my stuff, but I can contaminate myself, but somebody looking at me saying you just made a mistake makes a big difference. They also, here at Emory, we also ensure that people get monitored. And there's been a lot of effort in ensuring that, okay, we're supervising you, go in and out of the unit every 12 hours, you take your temperature. So a lot of things that people say, well, you need to quarantine people, you need to make sure they take their temperature. That was established here, that was put in place from the very beginning, and something that has been done with everybody that's worked there. Limiting the number of people that go in also has been very critical. How do you handle people who die? Well, handling of bodies has to be kept to a minimum. You essentially, leave all the lines in place, do not wash the body, you put it in a plastic bag, which you then put into another plastic bag, et cetera, et cetera. But the most important thing is that don't embalm, you proceed with cremation, and these are all great instructions, except in most of the countries in Africa, they don't have crematories, and this is against, this is not what the culture looks like. So how do you adjust to a culture in trying to address, how do our recommendations that make sense and can be made sense locally, I think is one of the big challenges that everybody's facing with. Somebody who works with Doctors Without Borders was telling me, they realized in one of their facilities that where they were disposing the bodies, you can essentially see it from inside the healthcare facility. Well, not a very good idea, right? That people that are in there being treated can actually be seeing when bodies are being disposed at the same time. You sort of want to have a little distance into those two things. But I want to remind everybody that in the US, there have been a total of 10 patients. The outbreak is really not 10 patients in the United States, and I think we as Americans have focused so much about, it's been surprising to me how everybody in the public is so concerned about it. At some point, I think some people thought that everybody in America was going to die of Ebola at some point in time. And the problem is really this huge outbreak in West Africa that is out of proportion, and that's what we need to focus our efforts in. That's where we need to really emphasize as a global community. And the Ebola in West Africa, the outbreak is simultaneously a public health crisis, but it's also a humanitarian crisis and a human rights crisis. And we need to remind ourselves of that if we just address it as a public health issue, we're forgetting the other components. People are being displaced, kids are not going to school. This is going to have tremendous implications long term. But we need to think, about as public health, we frequently go in there and say isolation, quarantine, this is what you need to do. But in reality, we need to, think about the ethical, human rights, legal implications. And as it says here, Ebola is a human rights crisis and therefore needs a human rights response. And I think we need to remember that as we're talking about what do we do in countries in Africa to confront this epidemic. And we can talk about some of the human rights considerations that are even applicable here. You know, how do we ensure healthcare workers' recruitment, selection, training, rotations, incentives, supervision? I mean, it was really interesting when a friend of mine in New York called me and said, so how do you guys decide who goes into that unit? And I said, well, a lot of it is based on volunteer people. And she talked to the nurses at her hospital, and they said, volunteers? Not at my place. You know, they said, we're unionized. You want us to go in there, you got to pay us double. You know, this is not volunteer phenomena. So, you know, what are the risks for healthcare workers? How do you deal with communication? How do you deal with stigma and discrimination? How do you deal with people that have been infected? In the communities in Africa, many people have survived and then go back to their communities, have been killed because they're at risk of, quote, they're thought to be at risk. So how do you ensure that that doesn't happen? There's a lot of discussion on quarantine, and quarantine remains an important part of the strategy to contain an infectious disease. But I think you need to rethink, quarantine is something that we continuously need to remind ourselves, what is it used for? How do we guide the decision? How do we use quarantine? What's the public justification? And you saw right before the elections in November how many governors were using quarantine as a way to say we're responding to Ebola in a very effective way. It wasn't based on science, it was just based on politics. And how do you use that in an appropriate way, I think needs to be looked at and be very careful about. So I think we can say that Ebola is not the problem. Ebola is revealing the problem and understanding in these countries and understanding the context, the culture, building trust, teaching the why. You know, the lack of healthcare systems is something we need to continue to remind us. We in public health have been for years saying we need to strengthen public health systems around the world, but really haven't done it. I think Ebola is a good opportunity to finally begin to address public health systems and healthcare systems. We need to think about community healthcare workers. They need to be paid. I mean, volunteers just don't work. At some point in time, we need to address that. And I think we need to involve the communities about what they're doing. And I'll just put this as an example. This is a document that essentially says, you know, we need to think about Ebola and how do we get the community involved? And this quote I think is wonderful. We even prefer war to the Ebola war, because if you hear that there is war coming in your area, you can run. But when this Ebola, you don't know who has it and who doesn't. So again, involving the community and understanding the response, I think, is critical. And I'll end just by acknowledging a lot of people that a lot of the slides have been provided by people. The Ebola team, I want to acknowledge Dr. Ribner and his team that have been really fantastic. I mean, they're models and they're doing enormous amounts of work, training around the country and around the world with the response. I mean, today, Dr. Kraft is in Geneva, and I mean, they're like essentially, Emory's putting its fingers in a lot of places just in this global response. Pierre Rollins from CDC gave me some of the slides. Dabney Evans, my department, and Jeanette Warner, my wife in pathology, has also provided some of the slides that I showed. So with that, I'll end and happy to take any questions later on.
The preceding program is copyrighted by Emory University. This program is brought to you by Emory University.
Thank you. Our next speaker is Ms. Susan Grand, who is the Chief Nurse Executive of Emory Healthcare and a fellow in the American Academy of Nursing. Susan's work in healthcare over the last several years has been focused on patient safety and patient and family-centered care. She was certainly part of the leadership team providing the safe and successful patient care of those diagnosed and treated here at Emory. Susan is a member of the Emory Ebola Task Force and serves as a member of the State of Georgia Task Force on Ebola. Welcome.
Thank you, Deb. I just want to thank the Planning Committee for inviting me to speak today, and wanted to say that I'm speaking on behalf of, as I go through this information, on literally a team of over 100 people across Emory, not just at Emory Healthcare, but at Emory University, who were a part of taking care of the 4 patients that we had the privilege to take care of here at Emory. As I go through this, I'm going to just talk a little bit about, share a little bit about our experience at Emory in taking care of the 4 patients, and then talk a little bit about what's going on in the Georgia Ebola Task Force, Governor Deal's task force, and then I'll touch on some of the national efforts that we've been involved in as well. And I have to say I was very happy to see that Dr. Bruce Ribner was here this afternoon, because I know that he'll be able to also help in answering some questions that you might have about some of the work that's being done. But he's, under his wonderful leadership, we've had an unbelievable experience here. So with that, whoops. Okay. So just for those of y'all who are not aware, and I'm hoping that you are, but just in case, Emory Healthcare is the largest and the only academic health center in Atlanta, which is highly unusual for a city of this size. So we're kind of in a unique position. We have 6 hospitals as of right now, and I say that as of right now because things are changing all the time in the health system, but we have 6 hospitals across the metro Atlanta area, with the furthest one out north in Emory Johns Creek area. And we have a number of physician practices. We have over 20,000 employees and over 5,000 physicians at this point at Emory Healthcare. I show you this slide as just as a foundational slide as I talk through some of the work that we did with these patients at Emory. This is a picture of what we call our culture slide, basically, and it represents the attributes in our culture that we've actually worked very deliberately on over the last 8 to 9 years to really come to a place that we provide the most patient-centered care as possible. And the attributes that we are talking about is patient-centeredness and really meeting the needs of patients as defined by them and their families, but also shared decision-making. And when I say that, what that means is that we aspire to have really tap into the resources that we have among all of our thousands of employees and physicians to really have the experts making the decisions about care, and that it's not really a top-down organization. That we also have a fair and just culture, meaning doing the right thing at the right time, and staying true to that, but also being transparent about that and being open and creating a learning environment when we make mistakes. And then also cultural competency and diversity, and really celebrating the cultural diversity and really building on the strengths that brings to our culture. And then the biggest attribute that we've worked on that you'll see as I talk about our experience is teamwork. And all of those attributes really come alive with teamwork. And we've been very deliberate and still have a lot of work to do, but have been very deliberate over the last several years in working to build true teams that work together. And I can't imagine a better example of teamwork, not just in the immediate group that cared for these patients, but truly across Emory Healthcare and Emory University, that we came together as a team, as a community as well. So if you all recall, July 30th, this was a picture of Woodruff Circle, and then August 4th, where we ended up. And as you all know, we got a tremendous amount of media attention as news went out that we were going to be taking the first Ebola patient in the United States, Dr. Kent Brantley. And as you know, we had a lot of scrutiny initially and a lot of concern about why would we do this? Why are we making this decision? Why would we bring Ebola to the United States? And it was very clear across the board, regardless of who we were talking to, and again under Dr. Bruce Ribner's leadership, that we felt as though this was the right thing to do, that if we could not take these patients, who could? And we had been working for years to develop this special unit for 12 years and a team that was equipped to take care of these folks, and this was precisely what we were here for. So we said yes, and you see some of the headlines that were out then. So if you recall, we took the first two patients. Our first two patients were two humanitarian aid workers who became infected in Liberia. They came in the first week of August. Both came to us, transferred by ambulance to Emory University Hospital, and they were 3 days apart, first being Dr. Kent Brantley, a male, 33-year-old male physician, and then the second, Nancy Reipel, who was a 59-year-old female missionary, and she was at day 15 of her illness. The media continued, and we talked about and were very focused on that we were ready. We were ready because of the training that had occurred over the 12 years of the team who had been involved. We had our special unit that Dr. Del Rio also showed you. We were equipped from a facilities standpoint, a team standpoint, and that was it. That was the answer. However, I remember one person asking us, well, yeah, you had the facilities, you had the equipment, you had the team, but what is it that makes an organization be able to say yes to something like this and go through and talk to and speak to the level of scrutiny we had received? And it really was about culture, that we really believed that the work that we had done in creating a culture of teamwork and being able, and of safety, to take care of our patients and be patient-centered, that really positioned us to do that. So let me give you a little bit of information about the team itself. We had initially 19 critical care nurses, and if y'all recall, we had our first patient, and then our second patient came a few days later, and very quickly we realized we did not have enough people to take care of these patients because of the intensity of care that they required. And so, as Dr. Del Rio said, we talked with staff. We had our experts, if you will, who had been involved in training with Dr. Ribner for a number of years, but we needed to cast the net a little bit further. And so we had other critical care nurses who stepped up to the plate and volunteered to participate. And all of these folks that you see on this slide, they were all volunteers. Everyone stepped up and said, I want to be a part of this. And when I say volunteers, I mean that we didn't force anybody to work on that unit. We did pay them. So, but they did volunteer to do that. And as Dr. Del Rio said, we learned later that in other facilities who either struggled or were debating about whether or not they could actually manage Ebola patients, we learned very quickly that that was not the case across the country. So it was something, again, that was unique to our culture that we attribute to some of the work that we had done. But we had 5 infectious disease physicians led by Dr. Ribner, and we affectionately call them the G5. And it's really an amazing group of physicians and leaders and collaborators who really set the tone for how we were going to care for these folks. We had a number of consulting physicians, including physicians from critical care, anesthesia, nephrology, who lent consulting services to these patients. Emory University Biosafety Office, who played an instrumental role in the creating the safe environment from a practice standpoint for the team, but also going forward, and I'll talk about it in a few minutes, our training and preparedness efforts going forward. They did assessments across the system of all of our facilities and entry points to make sure that we are ready to care for patients should they present to us. Lab personnel, spiritual health, you see the group. EVS, facilities, occupational health, literally over 100 people. Excuse me. So, I'm sorry, I think I've got a slide missing here. So as we went into this, we had a couple of assumptions for the team. Number one, we were going to limit the number of care providers in the room to make sure that if we were going to really provide a safe environment, that we wanted to make sure that people were equipped and they were trained to do what they needed to do. So this was about safety first, and we talked about, in order to be patient-centered, we have to be staff and physician-centered to make sure that they are safe, and in order to make sure our patients and the rest of our patients in the hospital and our other employees and our community were safe. So only direct care providers in the room. No one was allowed in the room unless they had mandatory training and that they were able to check off on that training. There were some folks who went through training, and if we didn't feel as though they had met the training criteria, we did not allow them to go into the room. So it was a very strict protocol to get to that point. It was very critical, and the reason why we had critical care nurses in the room at all times was that because of their scope of skills and their ability to manage patients who were on a ventilator or needed dialysis or physical therapy or occupational therapy and those types of things. So we called these nurses the Navy SEALs of nurses. So they really had all of that skill set to care for the patients. The readiness also included orientation for all of the SCDU staff, and this was education and orientation that actually started when Dr. Ribner started this unit. There were other trainings and education around the care of these types of patients over the last several years. They also trained on serious communicable diseases, the policies and procedures of the unit, and the procedures of how to actually take care of patients in those rooms, and as well as looking at personal protective equipment and the donning and doffing of that. They trained specifically and obtained competency in donning and doffing of PPE. There was the utilization of the buddy system that I think, quite frankly, was adopted in other places as a result of this, done at Emory as we shared best practices and learning. The buddy system basically was when someone was donning or doffing the PPE, that there was someone observing them as they did it to make sure that they met every step of the way so that they would safely don, and more importantly, doff the PPE. There were extensive waste management protocols, decontamination and containment protocols that our waste management folks and EVS were involved in, and then also handling of specimens. So they all went through that training in order to be a part of this. And then the culture of safety is the big one. This was, and I think Dr. Del Rio mentioned this, the culture of safety came first and foremost. There was a shared accountability for safety, and the thing that was very apparent that the team it was quite impressive, to be honest, to observe this. Everyone left their role at the door when they walked into those rooms. The hierarchy was left at the door, and physicians and nurses worked as partners in that room to take care of those patients. And there was an environment that was created within that team that it was not only safe, but expected to speak up if something seemed out of whack or something was out of the ordinary or abnormal or different from the day before, or from the hour before, or whenever. And that was something that the team stayed true to throughout the entire time. And of course, the communication around that was paramount. There were daily team huddles, and I'm going to talk about that in just a second, but every day, the entire team, and I am not exaggerating, Dr. Ribner can attest to this, I would round into the unit to check in on how people were doing, and every morning, the entire team, whether they were working there that day or not, was in that room. People would call into the room, along with the caregivers who were there that day, the physicians and nurses and others who were there that day directly caring for the patients, and they would actually talk about any concerns. They would give report on the patients, how they were doing, their status, their medical status, et cetera. But then they would talk about protocols and procedures, what's going well, what's not going well, what do we need to change, what do we not need to change. So it was a team effort the entire time. And then also the team was very committed to and deliberate about including the family members and the patients themselves and the team. A lot of discussion, a lot of questions have come up about how do you provide nursing care to a patient who is in that level of isolation. And our nurses have responded, well, you can always hold someone's hand even if you have PPE on, and you can touch them and be present for them and talk with them. It was critical that the family members were a part of that dynamic as well. And so the team facilitated, whether it was outside of the room between the glass, facilitated interaction between the family and their loved ones. So I've talked about the team, and one of the things the team did was they had what they called family rules, and I realized that, you know, they really were the Navy SEALs, this whole team of nurses and doctors and lab, everyone, facilities. And I realized that the Navy SEALs had a little culture of their own, and they called it the family rules. And I walked down to the unit one morning, and they said, no, they're in the family meeting. And I said, well, am I allowed to go in there and, find out what's going on? They go, sure. But what they did every single morning after they would go through report, they'd say, let's recite the family rules. And they would all recite these bullets, and they would just kind of yell them out, and each person would just volunteer them. But you notice, follow all standing operating procedures to the best of their ability. Ensure that others follow the standard operating procedures. Report all accidents and or near misses. Report symptoms that match the pathogen. Report any new medical conditions. And that was something they recited every single day, literally till the last patient that we took care of at Emory. And as you know, we took, after our first two patients, we took two more. One 43-year-old male physician who came from West Africa back in September, and he stayed with us the longest time. And then one of the nurses from Dallas, the second nurse from Dallas, who became infected. But both discharged successfully after their care here. So really it was our mission in action. It was what we were all here to do and why we come to work every day. And it really came together with this, with the incredible teamwork that we had. One of the things, some of the headlines that had come out over the course of that period, and I had heard so many different people, whether it was Dr. Ribner or Dr. Varkey or some of our nurses or any of our leaders would talk about, the importance of us doing this to really contribute to the general knowledge around the care of Ebola patients. And that seemed to continue to prove to be true, at least within this country, in contributing to the body of knowledge on how we actually respond and care for them. So just to give you a little bit of an idea, and I apologize for the font change there on the slide, but just to give you a little idea, communication as we went through this whole experience was critical. And it wasn't just communication, but it was really about education and educating our employees, but also educating our community. Because if you recall, there was a lot of misunderstanding and fear in the community at the time when we initially accepted these patients. So we did a number of things. We had communications that went to employees and physicians from John Fox, our CEO, letting them know that we were going to be accepting these patients. We had a number of town hall meetings at all of our hospitals and in the clinics to answer questions for our employees and physicians to make sure not only that they had information, but they also could get the information they needed, but they could share that information. We had a lot of folks who were worried about their families, kind of along the lines of what Dr. Del Rio said. We had folks who were working at Emory and said, well, my family's afraid I'm going to bring home Ebola. Well, no, we need to do some more discussion about that. So we spent a lot of time and energy on communication. And these are just some things that we have on our intranet. And I encourage you, if you haven't gone to our webpage, the Emory Healthcare webpage, there's a number of communications and information about Ebola, including videos. And so that was done by our internal communications at Emory Healthcare, but also our Emory University communications with and Nancy Seidemann's here, and Vince Dollard. And so a great team effort. I'm just going to go through these just as a few examples. So with that, we have a couple of things just to make you aware of. Governor Deal had appointed an Ebola task force for the state of Georgia, and the purpose of it was to really assess our current state in terms of our preparedness as a state to care for Ebola patients. This committee has been chaired by Dr. Brenda Fitzgerald, who is the Commissioner of Public Health for Georgia, and it has representation from GMA, the Georgia Hospital Association, the National Guard, University System of Georgia, Emory, of course, the Atlanta Airport, City of Atlanta. So a broad group of folks who have worked pretty hard to make sure that our preparedness efforts are coordinated across the state of Georgia. The task force in public health put into place a three-tiered system that you may be familiar with, that we have 7 hospitals across the state of Georgia that are identified as hospitals who can care for Ebola patients. We have other hospitals who have been identified who can diagnose as the second tier, where they have specimen collection and testing capability, and then the identify and isolate hospitals as well. And those are across the state of Georgia and were coordinated by public health. These are just a couple of things that you can get an idea of some of the activities that public health has been involved in, and the task force has coordinated everything from the screening of people in the airport to public health tracking of folks who do come through the airport who have a potential exposure, down to the three-tiered system in caring for patients. And that is the Department of Public Health website that is a result of the task force work. And it's a wealth of information. And what's really exciting to see is that we have a lot of the information in this website was information that actually had come out of Emory's learning. Some of the national preparedness efforts we are actively involved in. I know Dr. Ribner can speak to this as well. And CDC identified, it's not 35, it's 49 now, hospitals who can care for Ebola patients. And Emory and University of Nebraska have partnered and worked with CDC to train facilities across the country. So there's quite a bit of work going on across the country around these efforts. And we are collaborating with them. And then last, we have been actively involved in creating guidelines with HHS around Ebola preparedness. We have the Assistant Secretary of Preparedness and Response, Hospital Planning and Response work that we've been doing, and that has included not only work around preparedness and education, but also around potential funding for facilities who are actually assisting in this work, because as you can tell, there's been a tremendous amount of time and energy that has been dedicated to this on our part. And then we have many other things. That's not a comprehensive list, but it gives you an idea of what we've been involved in and what's going on around the country. So thank you.
The preceding program is copyrighted by Emory University. This program is brought to you by Emory University.
Thank you, Susan. And our final speaker for today, and then we'll go to the panel and open us up for discussion and questions. We are very fortunate to have, joining us from Liberia, is Counselor Jallah Barbu. He is the chairperson of the Liberian Law Reform Commission, an independent organization with the mission of ensuring that Liberia's laws are fair, simple, accessible, and responsive to all Liberians. He received his bachelor's in law degree from the Lewis Arthur Grimes School of Law at the University of Liberia, and he's received his master's of law as well as his doctorate from the University of Indiana Maurer School of Law in Bloomington, Indiana. In addition to heading the Liberian Law Reform Commission, Counselor Barbu teaches at the Lewis Grimes School of Law in Liberia, and he is the co-author of Liberia's first constitutional commentary and author of Liberia's first constitutional law course book. He is the former Secretary General of the Liberian National Bar Association. Welcome, Counselor Barbu.
Thank you very much. Thank you so kindly. I appreciate the introduction. Thank you very much. All right, just before I speak on the few issues I have to speak on, let me say first, you see on my chest I have here, Ebola is real. And that's true, Ebola is real. The second thing I'd like to say is, after listening to the two speakers, before me, I'm just thinking if we had just 1/10 of what you're talking about here, you would not have been, afraid in the U.S. in terms of, what Ebola would do. The third thing I'd like to say is, I'm happy to be here to share with you all my own experiences. And I submitted to the organizers here, I think 18 slides, which I'm not really going to go into anymore, not because of time I can run through them, because I know they've touched on many of them. I will go through a few of them, but what I will do is to explain to you after I have lived through Ebola. Because I was in Liberia when we had this situation, and I lived through it very well. And then I came to the US, and I experienced quarantine for 21 days. So I just like to speak to them a little bit, even my experience at the airport, so that I will give you some idea about what it means, to partner in the fight against this kind of situation. Finally, I just want to ask the organizers, you can put my slides and this piece of paper, set of papers I have here in wherever reading room you have. And this one is basically a kind of research I'm doing in Liberia on the impact of Ebola. What do people think? What are the 3 most important lessons we've learned from Ebola? And it's just across the board in, all over Liberia. And what I did is, it's an independent research work. There's no name, in terms of who said what. So you will not be able to, align it with anybody. So you can use it as best as you want, okay? Sure. All right. First I say, thoughts on Ebola, thoughts about Ebola. And these are my own thoughts. 1, it's a potential instant eliminator of an entire group of people, but they have to be in physical contact. This is important for us because in Liberia, when we heard of Ebola, it appeared to be a death sentence. Once Ebola came to the country, we would all die. And so it was mostly about don't go around anybody. So we didn't understand that, you have to be in contact with this person some way, somehow. Otherwise, you're not going to be infected by that. And I say it's an unimaginable, unseen, and unexpected terror, and a bag of mental torture. There are many nights you will not sleep, basically because you're wondering, did I contract Ebola today? Did I come in contact with anybody who had Ebola? Is any of my relative suffering from Ebola right now? So on that basis, you wouldn't sleep. And then I said, anyone and everyone who realizes its potency and borderless reach will understand that Ebola is real. There is no way that I will see anybody in Liberia except that person is sick, and I say he or she has Ebola. So on that basis, people will come to my office, in my home, and I wouldn't know why they have Ebola. But at the same time, people will leave and go to other places, from one county to another. You wouldn't know why they have Ebola, and I will speak to that a little bit. So having said that, I would jump a little bit, talk about the Republic of Liberia. I'm going to go and talk about basically one thing here. That is, we have 2 seasons. The rainy season, which is the wet season, and the dry season. During the rainy season, away from Ebola, we have all kinds of illnesses. I mean, malaria, he spoke of, fever. You talk about typhoid fever, whatever that is. All kinds of illnesses. And people definitely just get sick. Now, if you have those things and Ebola comes into play, you wonder, where are we? In essence, because the symptoms are the same, and because it's happening during rainy season, as it was when Ebola came in, as I will explain, it became difficult to treat people who have malaria because you didn't know whether it was malaria, whether it was typhoid, whatever else it was beside Ebola. So that caused us some problems here. All right, so I just want to jump to the third slide that really talks about, the timing of Ebola, the entry into Liberia, meaning the rainy season and what have you. But that was not the only thing. When you have a governance system that comes under attack from those who are governed, and they become very suspicious of the government, it creates all kinds of difficulties. So Ebola came at a time that we have very serious political disagreements, and suspicions against the government. And so people didn't believe that it was a disease that had jumped into the country and it needed to be treated. What we, meaning Liberian people, saw it to be was another way of getting some money from our coffers. And so when the Ministry of Health requested just $1 million to begin to fight Ebola around March to April, there was serious resentment, basically because, well, they're going to eat this money again, So that was a problem. The second thing is, Liberia is, a mix of many cultures, and for that reason, we do have all kinds of tribal beliefs, traditional beliefs. So people did not really think Ebola is a sickness. They felt, and up to the level of the president, there were accusations that the president had brought in somebody from the ocean, and the person just came to spread this disease. And there is no way this disease will go away until that person from the ocean or that whoever that angel or that devil was, decides that it will go away. So that kind of suspicion also affected us seriously. All right? With all of those, the government had to do something. Basically, the government had to take some actions, make some decisions, policies. But those policies the government had to make will impact the larger community. On that basis, because of the cultural differences, and I'd like to speak to 2 major groups here. One is American Liberians, all of these people who we say left Liberia, and the U.S., free slaves, and went back to Liberia, versus indigenous Liberians, those who we see as being the true owners of the land. They do have their customs and their traditions, while the Westerners, so to speak, have their customs and traditions, or their way of life. How we brought these 2 together will be very difficult, especially during this kind of time. But the government had to do this. In the process of doing this, the policies, the actions and decisions came into conflict with cultural practices, which Doug and the previous speaker spoke of. That is, don't bury people. Call somebody in when your relative is sick. Don't touch the sick person. Do not shake hands. And let me say to you about shaking hands. If I shook somebody's hands in Liberia, nice handshake, say, oh, how you doing? And we did everything else and didn't snap, and our hands left each other. Say, Jallah, come back. I'll say, why? Our fingers didn't snap. What do you have against me? Because of that, what do you have against me? It is clear that handshake, physical contact, is very important in our culture. Now that we were stopped from doing that, it created a kind of serious tension between, why do we have to do this? At the same time, we believe, we have this very belief, serious belief in the deity, in God, in some kind of God, And for that reason, those who believe in Christianity, those Christians who believe in God and their faith very strong, believe that they can pray for the sick and the sick will get well. But the Bible says, if you're sick, they, lay hands on the sick and they will get well. So pastors want to lay hands on the sick, but pastors cannot lay hands on the sick. So pastors therefore believe that the government is now trying to suppress Christianity. That is the reason why they do not want us to lay hands on the sick. We will lay hands on the sick. When they do that, well, you know the result. Right? I don't have to go into that. Let me quickly, these policies, as I've already explained, came in contact, clashes between cultures and tradition. There was resistance for washing hands. People think in Liberia, when you talk about culture and traditional practices, it's just about, the people in the interior or uneducated people. No, not so. Even in Monrovia, there were educated people, the so-called Westerners, not necessarily, people who belong to the West, but who have come here, have lived here, have had education, have gone back to Liberia, who said emphatically, no, I will not wash my hands in public because I was clean when I left home. There is no reason why I should wash my hands with chlorine water. I am not going to do that. That definitely meant a big resistance. Now, if we are following those who are educated, those of us who are not educated following those who are educated, and we find out that they too are resisting, then it creates even greater doubts in our minds as to the reality, the factual issue regarding, Ebola. The net result of all of this, conflicting government interest versus public interest, we realize that from all of this, national capacity could not solve the problem. Because we couldn't come together. We just couldn't agree, couldn't agree. So what therefore was required was some kind of intervention. Thanks to the international community, thanks to the US, that sent so many people to Liberia to help us. Let me say, our own ideas about US intervention. Before the US sent people to Liberia, our military had already gotten involved with the process, and people got, killed and wounded, from the actions of our military. That meant, therefore, that we didn't want military intervention. And so when the U.S. sent military personnel to Liberia, that raised all kinds of doubts. But these people, including the U.S. ambassador, said to us, you should not involve the military. Why is it that the U.S. is sending military people to Liberia? Well, Liberians would think that way because we train the military to fight war, wouldn't it? And, well, a few military personnel in the past, did some medical work, but very low level, did some engineering work, very low level. So we didn't expect that military people would take part in, the fight against Ebola as the U.S. military were doing. So clarifications had to be made. The suspicion was, apparently the U.S. government has sent these people to come and overthrow the Ellen Johnson Sirleaf government, remove her from power. Another suspicion, maybe they are here to arrest warlords and take them for trial. So with those kinds of things, it tells you exactly that people really need to be educated. Otherwise, it creates a lot of situation. Moving on, right? The implications, everyone realized later on because there was so much death, so many cases. People were dying. You can't imagine if you think, here in the U.S. you were under fire and you were afraid and you thought, you would be brought down by Ebola. Imagine what it was to be living there and seeing it every day. I can tell you, to go to my office every day, I had to pass by at least 2 Ebola centers every day, at least 2. And the major one was at ELWA. And that one, you will see people outside of the Ebola treatment unit, lying down on the ground, praying to be given a space for treatment, and they would not find it, and then they would die. There were people who slept on the porches of other people around ELWA, and the next day, they'll be gone. Now, I had to pass there every day, every day. So I know what it means. I really know what it means. Beyond that point, I had to also do a lot of work in my office. Not work in terms of paperwork, but managing my staff. You can't imagine what it's like. When a staff walks up to you and says to you, I don't know, but I'm just not feeling well. Like, all right, so what's happening to you? I said, I do not know. Okay, have a seat. Can we talk about this some more? Counselor, I really want to go to the hospital. Which hospital you want to go to? I don't know. Figure out something for me. So what did I have to do? I had to engage a private clinic, right? And speak with them and say, look, you know what, gentlemen? Here's what we do. My commission will pay you. We'll buy you whatever you require. But observe all the safety measures and focus on my staff. When others come in, please be careful. So I had to do that. And so we spent so much money in short time to cater to our staff. At the same time, we had to ensure that those who were not on duty because the government had authorized us to reduce the staff in terms of congestion, we had to find a way to monitor those people. But in Liberia, the way to monitor is by telephone. Even if you gave them a piece of work to do, they will ask you, how do I submit this work when I cannot get in the taxi to come to the office, when I do not have internet? How am I going to submit the assignment you gave me? So that became a problem. Best thing to do, let them loose as much as possible, believe in them as responsible people, and always call them once in a while. So we had to do that. But if they got sick, then they had to come back to the commission to be sent to the hospital to get treatment. Something that was not in our budget, right? Let me move on a little bit. All right? So because we've had all of this realization, at least in Liberia, what we had to do was to observe basic health and hygiene. So somebody will ask the question, well, I mean, just in between July and October, you had this serious increase in the number of deaths and in the number of infected persons. How come we just rushed down quickly by November, December? Answer, not because the government imposed all kinds of regulations, no. Not only because we had international intervention, no. Basically because all of us had a realization at the point that indeed Ebola is real. And because of that, people had to immediately begin to observe some of these practices that will ensure that they are not infected. We began to wash our hands. We began to offer, sometimes from our own pockets, buckets and chlorine, and other things for people to use in their communities. We began to have all kinds of community meetings. We began to have awareness, and we began to engage others. What that means, therefore, is if the people are not educated, if they're not made to understand what's happening around them, there is no way they're going to, cooperate. They will try because the law says so, but they will break the law every time because they do not understand the reason why you want them to behave, you've authorized them to do. That is very important. That's why the Law Reform Commission is now engaged seriously in a review of the public health law. And just as Doc said, Ebola is not just a health issue. It's a human rights issue. You cannot stop people from moving from one point to another simply because you want to contain Ebola. When you restrict them, they're not working, they don't have food to eat, they have no resources, they have to go out every day to find food, come back home for their families. And you say, don't go. The next question is, how do we survive? What are you bringing for us? Did we have an experience as such as a commission? Yes, we did. Some of our staff just woke up in the morning and they were quarantined and couldn't move, can't go anywhere. And they would just call on the phone. We are quarantined, we can't go. I mean, the people didn't tell us this thing, they just locked us in this morning. We don't have food. We don't have water. We don't have this. We have to underwrite the cost. But we ourselves don't want to go into Ebola-affected places. So what do? Call the medical people, call the police, or some security personnel and say, look, we have our staff in this area. The area is quarantined. We want to send food, rice, oil, salt, you name it. We need to send water as well. Can you facilitate, carrying this food to them? Then we agree. Then we give it to them and kind of structure it and say, when the people get to you, call me. When you meet the man, call me. So the police or whoever is carrying the items has to call me. And then that person has to say, yes, I'm with this man. And then they will receive it. That way, we have some coordination. In the community as well, we had to do the same thing. Help people. Otherwise, it would have been difficult. Now, these are all the lessons learned. Every actor in the fight against Ebola has gained at least one valuable experience. For the government of Liberia, the government is clear that we had thought we had so much in place that will at least solve basic health problems. But we also forgot that solving health problems is not just about having hospitals for people to go to. It's beyond that. Solving health problems, solving other immediate problems require educating the people, public awareness, so that they will live in a more hygienic way, so that their lifestyle will not be one that is tied to culture and tradition. Rather, their life will develop culture and tradition in a way that we see that culture and tradition don't keep them down. If you say to somebody, don't watch your dead, and they said to you, but the washing of the dead is not about me. It's about what's going to happen after life. And you tell me not to wash the dead? So if I do not wash the dead, what do I do next? If you can't find that, it's a problem. They need that answer. If you say, don't touch the sick, like, all right, that's true, but that's my child. If I don't touch my child, who's going to touch my child? I prefer death than my son dying or my daughter dying before me, So having said all of this, the GOL and the Liberian public includes businesses as well as the ordinary people. Don't close your business down. Don't run away. That's not what you should do. In good times, you were there with us. In bad times, stay there with us. So that has been a problem here. Now, let me just discuss briefly my experience. After saying all of this about Liberia, then I come to the U.S. I really had to come, to do some work here. We're doing this constitution review process. And I have some of the folks here who are working with me on that, how to come to work with them. So first thing is, I'm supposed to come here, be here, work with them, and what's happening. Buy my ticket, know I'm coming to Indiana, and everything is set. And I speak with some of the people in Indiana just about, 9, 10 o'clock Liberian time, And by 3 o'clock Liberian time, I receive another telephone call. Jallah, you can't come to Indiana. Why? Well, Indiana is not prepared to handle Ebola cases. We know you don't have Ebola, but it's possible that anything could happen, so you can't come. All right, so I cancel my trip. No, you cannot cancel your trip either. So what do I do? Jallah, is it possible to go somewhere else, and then after 21 days you can come? Like, somewhere else. Where else is safer or, is prepared for this kind of thing, if not Indiana, where I know best? All right, I can do that. So I call my contact in Philadelphia. Well, I need to be in the States, but I have to be quarantined for 21 days. Can you find a place for me? Yes, but So you coming to live in our home? No, I'm not living in your home. I just want, a hotel that I can live in. Okay, I will find one. But I can't tell the people in the hotel that you're coming from Liberia. Yeah, that's true. So he doesn't say that. And I come to I come to Philadelphia. But to come to Philadelphia, I have to come to a port of entry, right? Before getting out. And I meet the security personnel at the port of entry. They're like, everybody from this country go this way. What's going on? And we sit there for almost an hour, and nobody's saying anything to you. You're wondering what's happening. And all of a sudden, somebody comes up and says, 1, 2, 3, please come to the desk. Fill in this form. Do this and do that. All of those are like, are we being tormented here? Finally, I get to the hotel. Well, my contact says to me, I didn't tell the people you're from Liberia, so you can't tell them. My conscience said to me, what if They brought somebody to the room, and say, well, clean the room the next day. I'm here for 21 days. What happens? So I'm battling that in my system. But what can I do? I have to let it loose. So every day I'm telling this gentleman, I really need to talk to you. I really need to talk to you. So one day he says, yeah, what you say? I say, look, let me be frank with you. I need to tell you I'm from Liberia, but don't panic. He says, what's going on? I said, well, fact of the matter is I'm here, I'm okay, I'm fine, everything's okay. So don't worry about it. I'll be fine. If there's anything, I will let you know. Flip side to that is you have authorities who are monitoring you. They gave you this fine, thermometer to take your temperature. And every day they're supposed to call you or you call them once. Last night my temperature was 89. This morning is 92. Every day. And after 2 weeks, they call you back and say, sorry, Mr. Barbu, but it seems all the information you gave us, we misplaced them. Can you please help us again? Like, what are you talking about? Are they checking on me? Are they kind of doing something I don't understand? You give it back to them. But let me say to you, if you are active, moving around, and all of a sudden, you have to be stagnant for even 1 day, not by choice, but because you must respect something, it's difficult. Flip side is, if I didn't do that, I would not create the kind of confidence I've created in the people in Indiana, in the people in Philadelphia, in all of you here, to say maybe, we can build the courage to at least shake his hands and say, welcome here. Maybe we will not even have built the courage to say we're inviting you. In essence, it's a win-win situation when all of the parties understand the benefits. Thank you very much.
The preceding program is copyrighted by Emory University.